Welcome to today's virtual event on the role of cryotherapy in the treatment of esophageal cancer and its complications, presented by Dr. Michael Smith. I am Patrick Clary, Eastern Regional Business Director for STERIS Endoscopy, and I will be your host for today's event. For your awareness, this presentation is being recorded. During the event, if you have any questions or comments, please submit them using the chat box at the bottom of your viewing screen. Questions will be addressed at the end of the presentation. We're honored today to present today's speaker and thank them for, and we want to thank everyone for joining us today. Our speaker today is Dr. Michael Smith, MD, MBA, Chief of Gastroenterology and Hepatology, Director of the Esophageal Program at Mount Sinai West and Mount Sinai Morningside Hospitals. Dr. Smith is also Associate Professor of Medicine at the Icahn School of Medicine at Mount Sinai. Dr. Smith, take it away.
All right, Patrick, thank you very much. And thanks to everyone for being part of this meeting for the American Foregut Society over the last couple of days. It's been a logistical challenge in the era of COVID-19, but we're so glad that all of you have made it. And I'm excited to talk with you some more about the role of cryotherapy in the treatment of esophageal cancer and related issues. And so I want to start out by just giving you a quick disclosure, which is that while I am a consultant for STERIS Endoscopy that now owns the TrueFreeze platform, all of these slides that I picked today and all of the data I'm going to show you, I've personally selected. This is my presentation, and it would be the same thing I would give you if I were giving you a grand rounds in a CME situation. So please understand that while we're obviously very grateful to STERIS for their support of the AFS and of this talk, that this is my own presentation. We're going to talk a little bit about the technology and then the role of spray cryotherapy in Barrett's esophagus, as well as balloon cryotherapy for both Barrett's and esophageal cancer. And then I really want to spend the meat of the talk where we've got the preponderance of data, which is in spray cryotherapy for esophageal cancer, and talk a little bit about where that platform can be used outside the esophagus, ending with my personal experience using the technology, and I'll show you some cases that I've taken care of. So let's start first with a discussion of the technology. So liquid nitrogen spray cryotherapy, or LN2-SCT, SCT as I'm going to refer to it in the talk, uses this extremely cold, -196 degrees centigrade liquid nitrogen. And that's going to freeze the tissue, and the freezing and thawing in this rapid and efficient energy transfer, where we're delivering about 25 watts of energy to the treatment site using a low pressure spray, is going to destabilize the metaplastic and neoplastic tissue, leading to an apoptotic pathway. And that's the death of those unwanted cells within the esophagus or whatever organ we're using this treatment in. There is no risk of fire as there is with some of the other ablative technologies that are out there. And it really gives you a flexibility compared to other ablative techniques in that you can treat over and through foreign bodies such as stents or mesh or other appliances. And because it's like having frost on a cold fall morning, and as much as I love summer, we're heading in that direction now. When it's cold enough, it doesn't matter if you're at the peak or the valley, you're going to see that frost. And that's exactly what we've got here. Unlike the paddle in RFA or the balloon, you don't need to make a direct tissue contact to have that energy transfer. It's coming through the liquid nitrogen that's spraying over the surface area, nooks and crannies, peaks and valleys. And that's a really important thing to talk about, particularly when we focus in on cancer patients. Now, you also can treat in retroflexion given the flexibility of the catheters that are used with the TrueFreeze device, and you can see the console on the right-hand screen and an example of an active freeze here in the lower right as well. And why is liquid nitrogen spray cryotherapy different than radiofrequency ablation or bipolar cautery or argon plasma coagulation? Well, the depth of injury, the depth of treatment is really impressive compared to what's out there, even with doing endoscopic mucosal resections. And you're able to treat as far down as the adventitia depending on the dosimetry that you use. And this nice study that was done by Alfonso Ribeiro in Miami, demonstrating in a pre-esophagectomy treatment setting or therapeutic setting that he could get a depth of injury all the way down to the outer edges of the esophagus. And so that opens up a whole new realm for us to be able to treat well beyond the epithelial surface. And we know that it's extremely well tolerated. Here's just one example of a study that came out from Solomon et al., senior author Arvind Trindad, where the pain associated with an endoscopic Barrett's ablation in this particular case, looking at the liquid nitrogen spray cryo versus radiofrequency, both focal and circumferential treatments, both immediately post-procedure and then 2 days later when spray cryo is getting its maximum effect in terms of triggering that apoptotic pathway, the numbers of patients who are requiring therapy for management of pain or reporting pain are statistically significantly higher in the RFA groups than in the liquid nitrogen group. And the pain medication prescriptions that are necessary also, as you can see in the graph on the right, are significantly higher for that group. So it's very important to recognize here that you have a treatment that is thought of as preferable in terms of its patient tolerance, but also patients who have an active lifestyle and want to get back out and on the go soon after their treatment is completed. This is a real attractant to them. So let's talk a little bit about spray cryotherapy for Barrett's. That's where its original intention was in terms of its desired use, with an extension out into the cancer field, as we'll talk about in a few minutes. So the efficacy of liquid nitrogen for dysplastic BE has been shown in a number of different studies. This is just one in particular that I wanted to show, the Gorbani study, where you could see that we had almost 100 subjects, the 2/3 of which had high-grade dysplasia, and all the mean of which, or the majority of which had a long segment of disease that was treated. And you can see that the rates for complete eradication of both dysplasia and intestinal metaplasia are quite good, in line with other studies that are out there, and very similar to what we've seen in terms of management with other ablative techniques. So using that as a background, let's just keep springing forward here. Important to recognize that the durability of response to the liquid nitrogen is also quite good. If you're going to compare this to RFA, here you can see a study from the University of Maryland, Bruce Greenwald's team, looking that even out to 5 years, the durability of complete eradication of intestinal metaplasia is quite good, and complete eradication of dysplasia and maintenance of that remission is even better. And they look really similar in terms of the curves that have come out from RFA. This is, for example, from Nick Shaheen, looking at the data from the US RFA registry. So the numbers are very similar. And so we have two techniques that have really come on the stage and are in prime time for management of dysplastic Barrett's and Barrett's in general. The difference is that we have some data that's now out there, and this was the first and seminal study in the salvage spray cryotherapy realm for looking at using this as a rescue technique after RFA failed to achieve eradication. The Samgupta trial from GIE, now published amazingly 5 years ago, knowing that complete eradication we were able to achieve in about 1/3 of the patients who were completely unable to achieve that eradication and remission with radiofrequency ablation. And there are other studies out there, but in the interest of time, I'm going to keep moving forward. We also know from study that my group put out there now also 5 years ago, looking at over 200 cases of spray cryotherapy being used on patients with both Barrett's esophagus and esophageal cancer, that it was safe to perform this technique on patients who were on blood thinners, who were actively taking them, because the blood loss was really minimal. In fact, the only case that had more than 10 mLs of blood loss that was reported was a cancer case with lots of angiogenesis, and the patient was on no medications at all. So blood thinners were not responsible for causing that significant blood loss. It was the tumor itself. But in other patients with esophageal cancer or Barrett's who underwent liquid nitrogen, holding those medications did not change the blood loss that was obtained during the procedure. So let's switch briefly to talk about balloon cryotherapy. As I said, this is a talk that I want to make sure it gives us a state of the art, and this is a technology that's out there as well. You'll see the case that Felice Nall-Sussman did on squamous dysplasia and cancer is a live course case that you'll see a little bit later today, video of that. When she uses the nitrous oxide cryo balloon to do that. A couple of differences with this technique. Number one, the cryogen is nitrous oxide, not liquid nitrogen, which is not as cold a temperature in liquid form as the liquid nitrogen. almost 100 degrees centigrade or so different. Secondly, as you could see from the picture on the left-hand side from a case that I've done previously, this is done within a self-contained balloon. So the liquid nitrogen spray that we talked about at the beginning and that I showed you is done with a catheter that sends the liquid nitrogen out directly into the lumen. This one is done in a balloon. Now, it's a soft, compliant balloon that can conform to the shape of the organ in which you're applying the technique. But you do have to go through the balloon, and the limitation of that balloon geometry does affect how you're able to deliver the cryogen. There are a couple of studies that are out there, and I'll just show you a few quickly. This is an efficacy trial that was looked at patients with Barrett's esophagus, where in fact, particularly in short segment disease, they were able to achieve complete eradication of dysplasia in the vast majority, and in a majority, complete eradication of intestinal metaplasia. There's one trial out there that's been published in the literature about cancer. We're going to get to that in just a second. This one, like the Sengupta trial, has shown that you can use cryoablation as a salvage therapy for RFA failures. Less data in the balloon cryo realm than in the spray cryo realm. And in the setting of squamous neoplasia, as I just alluded to a second ago, there is one trial out there from Mimi Canto and a couple of other sites looking at 10 patients with either high-grade or low-grade intraepithelial neoplasia. And in fact, in the treated areas, they were able to get a nice response. But again, as I will mention, because of the fact that you have to deliver this treatment through a balloon, you do have a little bit of a geographic limitation. For example, you can't treat a lesion that's overhanging into the gastric cardia, whereas we, with liquid nitrogen spray cryotherapy, can do a retroflexion in the stomach and treat in the retroflex direction, retrograde, and hit those tissues. So let's go back and focus in on spray cryotherapy for esophageal cancer, which is really the meat of what we're here to talk about today. We know from data that was published now 10 years ago by Greenwald et al., and you can see the list of the authors there, that in this group of nearly 80 patients that were enrolled in this trial, the vast majority of whom were patients with adenocarcinoma, there was a pretty impressive result, and that is that the intraluminal tumor went away in 72% of the patients who had undergone liquid nitrogen cryoablation for a T1 cancer. And in T2 patients, knowing that that's a more aggressive and invasive disease, still about a third of those patients were able to achieve a complete intraluminal response using the technology. Now, I'll point to you that this study was published in 2010. TrueFreeze did not come out until a few years later for commercial treatment, and this study was done on a much older version of the technology that didn't have laminar flow, did not have as flexible a catheter, and was a lot more difficult to perform. And so for those of us who remember using that technique, it's sort of the oldie but goodie, but incredibly difficult to use and not nearly as friendly to the endoscopist as TrueFreeze is. And so it's important to recognize that, that even with inferior technology, these rates really demonstrate that you can make a nice inroads on cancer using this technology. So let's fast forward a little bit further, and we could talk a little bit about Jim Barthel, who was at Moffitt Cancer Center and published this the year after the Greenwald study, where he looked at eradicating residual Barrett's esophagus, particularly dysplastic Barrett's, after definitive chemoradiation for esophageal cancer. And in fact, if you look, the 5-year disease-free survival rate was 75%, which is quite good. And what we were able to see from this study is that eradicating the residual precancerous cells, and the dysplastic Barrett's does not respond to chemoradiation the same way as the actual tumor does, helped to greatly increase survival rate. So if you're treating cancer out there, whether in the surgical realm or the GI realm or somewhere in the crossover space, recognize that after definitive chemoradiation for patients who maybe aren't great surgical candidates, using cryotherapy after that definitive chemo XRT can help you to ensure that all the precancerous cells are removed and improve your patient's survival. Now, we also know that there's a benefit not just for going after the primary tumor or the precancerous cells after you've chosen another therapy, but also to be able to palliate these patients. Here's a study that was published by Tufik Kachami from Arizona, nearly 50 patients with an unresectable esophageal cancer, where he delivered just under 3 cryotherapy treatments per patient. And you can see that he was able to improve the dysphagia score very significantly for these patients. And in fact, to do that in cancer patients with very minor adverse events that were related to it, just one dilation-related perforation, and in that case, there was just a rather large, bulky tumor that was really constrained the lumen, and it wasn't the cryotherapy that did it; it was the dilation where you had the perforation. And in fact, it has become very common for those of us who treat cryo patients or treat cancer patients with cryo on a regular basis to do both dilation and cryotherapy in the same session. Most of the time, the cryotherapy first, because it resets the extracellular matrix, which allows you a more durable and efficacious response to the dilation. But interestingly, and you take it on a little bit further, and I have the wrong reference here, I just realized in the bottom, but there was a nice study that's come out from Dr. Kachami as well about the chemotherapy and cryotherapy co-sensitization. In fact, he looked at a case of 21 cases of inoperable patients at 2 centers. And in fact, the primary outcomes were changes in dysphagia scores at 1 and 2 weeks post-cryotherapy. And as you can see in the results section, we had a 71% of those patients who improved at least 1 point on their dysphagia score at 1 week, and half of the patients at 2 weeks. So despite having inoperable cancer, without having to put a stent in, we were able to make a significant improvement in the dysphagia scores and allow patients to be able to continue to eat, both for enjoyment and for nutrition, and to do it without having to put in a stent. And as we all know, those stents can cause chest pain, those stents can worsen reflux, those stents can increase the chance of aspiration. So there are lots of issues with those stents that we don't see when we can just go in there on a regular basis and ablate to maintain luminal patency, and to do so with chemo and cryo at the same time, being able to drop those dysphagia scores. So it really, that combination therapy can be extremely helpful for our patients. And there, again, this is just the tip of the iceberg, but you can see there's lots of room here to keep moving forward and seeing how this will benefit our patients as we get more data. So putting all of that data together, appearing some time ago, and actually after the 2010 study, that was really the key focus for the NCCN when it decided to include spray cryotherapy in the guidelines. But the ongoing data, some of which I just highlighted to you, has kept it in the guidelines, both looking at it as a way to treat high-grade dysplasia, which they call T1S, but also being able to look at post-treatment surveillance for residual disease or recurrent disease, and then also for long-term palliation of dysphagia, as we just talked about with Dr. Kachami's work, being able to use the cryoablation for maintenance of tumor mass control and bulk control, in particular to relieve dysphagia. So before we go back and talk about my own personal experience with the technology in the cancer realm, I just wanted to remind you that as a platform technology, we really aren't just talking about the esophagus. There are lots of other areas where those of us who use the technology have been able to take it outside that realm. And I just wanted to spend just a second reminding you of the versatility of the platform. And in fact, in the foregut, we can treat benign and malignant esophageal strictures. We could treat gastric antral vascular ectasia, or GAVE, watermelon stomach, and we can treat gastric cancer. And in fact, I've treated a number of patients with those lesions, and it works quite well. Now, there are a number of folks who also treat at the lower end of the GI tract, radiation, proctitis, and rectal cancer being the primary indications. Those of us who work primarily in the foregut, maybe not an area we tread into with great frequency, but know that this is an option for your patients where that may be something that you come across in your patient's history. So let me end my lecture portion of the talk with spray cryotherapy. for esophageal cancer with my own personal experience. I want to show you some pictures of a guy who I treated in my last job in Philadelphia, who was diagnosed with esophageal adenocarcinoma, had an Ivor Lewis for it. Did okay for about 5 years, and then on a surveillance endoscopy had a recurrence of the cancer, had chemo XRT with a resolution, but shortly thereafter developed a 1 centimeter nodule. That was how it was billed to me on a surveillance. So his third tumor of invasive adenocarcinoma. He did not want to undergo any other therapies. He didn't tolerate the chemo XRT well. He wasn't a surgical candidate, so he was sent to me for cryoablation. And in fact, after only 3 treatments, you can see that there was quite a reduction in the bulk of the tumor from the left side to the right side. That was only 3 months later. And in fact, at 1 and 2 years after the initiation of therapy, you could see that the tumor really didn't exist intraluminally, hearkening back to that early data from Greenwald that I showed you earlier in the talk. And you could see that he tolerated it particularly well. His PET scans at 6 and 18 months actually showed no change in tumor size and no metastasis. He started missing some treatments for a number of different reasons that were more social in nature, and ultimately after about 30 months entered hospice therapy, but really tolerated the treatments well and got quite a long sustained period of time where he could hang out with his wife and his family and enjoy his time in the backyard, all the things in life that he didn't expect to be able to do when he was diagnosed with his third cancer. So I wanted to show you that just as a personal, one of several personal experiences with the technology in this realm. And the other one thing I want to show you, because I know people are a little bit concerned about the learning curve for this device, it's actually pretty remarkable. This is a second-year fellow who last week did this spray with me on a patient with esophageal cancer. He'd never even seen a cryotherapy case before. He watched me do 5 sprays, and this is the 5th spray. So let's see if we can get the video to go here. There it is. And you're going to see my fellow here is going to start spraying here in just a second. And now this is his first spray ever. So for those people who don't think that they could do this technique, here he is doing it by himself. I'm not actually touching the scope. I'm not touching the patient. And here he goes. And just watch this. You can see how easy this is. He's just going to spray. You'll see the endoscopic cap, distal attachment cap on there so that he's able to keep a relatively clear field and see the tumor. That's it. That's all he's needing to do now. And he's going to freeze that whole area. And once it's all turned white, he's going to go back. We're going to count 30 seconds for esophageal cancer, 20 seconds for Barrett's for each spray. And then we did this 3 times for each site within the tumor. And that's it. And you see how easy it is just to move back and forth and be able to get the site. So I'm going to stop the video there in the interest of time and just pull up my pull up the rest of my talk just to finish up real quick. And give me just a second here. And so let me just do, just to conclude here, we've got great data now showing that this is a technology that's efficacious in the setting of both Barrett's and esophageal cancer, looking at the ability to palliate as well as to treat primary lesions, and to have the chemo-cryo co-sensitization as a very interesting new wrinkle in our ability to treat these patients in a multimodal way, in addition to other endoscopic therapies, and to be able to use this technology and technique outside of the esophagus in other places in the foregut, as well as in the rectum as well, is really fantastic and gives us some great options. So with that, I'm going to stop and take a couple minutes of questions. Thank you so much for your attention. And Patrick, why don't you take it away?
Well, thank you, Dr. Smith, for this informative and insightful presentation. Panel, folks that are watching, if you haven't already, please submit any questions in the group chat. And with that, I have a question here from Dr. Chi. What is your experience with cryo treatment of refractory benign esophageal strictures?
That's a great question. So my personal experience has been that actually these folks can do quite well in the right setting. And again, what you can do is you can freeze the area of the stricture just before you dilate it. We know that the cryotherapy just hibernates tissue that is healthy. And when you do that, you kind of freeze the extracellular matrix and you prime it for resetting of its structure, so that when you do the dilation, it seems to hold the shape and conform to the shape of the dilating balloon and hold that shape for a longer period than if you just do monotherapy with the dilator itself. So I've actually seen some prolonged responses with that. I think it's part of what you need to consider, and in particular, those nasty strictures that aren't responding even to recurrent dilation. This is a nice piece to add to be able to make some tangible results.
Thank you, Dr. Smith. Great question, Dr. Chi. Another question from Josh Sloan. Does the spray exit from the catheter tip or from the sides of the catheter as well?
Yeah, Josh, great question. So in the older generation of the catheters, there was a side spray as well as a forward spray. Currently, we're using forward spray only, and part of that is because the smaller catheters that we have now allow for more tip deflection with the endoscope to be able to target your therapy. But stay tuned, there are some important advances coming out with the ability to spray not just in a forward direction that I will leave to STERIS to share with you as the technology advances. But some very exciting things coming out in that realm.
Another great question. Thank you. So in terms of someone who has RFA, you know, what role, when would you choose RFA? When would you choose spray cryotherapy?
So unfortunately, we have 3 minutes left, and this is about a 25 to 30-minute discussion. But what I will say is this: having used this technology now for over a decade, I feel very comfortable using spray cryotherapy as a primary ablation modality for the same patients I would use RFA. Sometimes the configuration it's a more expeditious case if you use the RFA, just because that can go in relatively quickly and particularly short segments. But in anybody who's got a floppy, tortuous esophagus, someone who's got scarring from prior EMRs where you don't have a nice flat surface to make tissue contact, patients on blood thinners, like I mentioned before, patients where the disease seems to be tipping over the lip of the EG junction and into the cardia, I find all of those cases are great cases to think about going to cryotherapy first. But I would not throw cryotherapy off the table as a first modality for treating regular run-of-the-mill dysplastic Barrett's because it works quite well and the patient tolerability is so good.
Great question and great answer. In terms of establishing a digestive disease program, specifically like an esophageal program, to be a comprehensive center, is this in your mind, you know, a necessary tool, or is this a nice-to-have tool in terms of spray cryo?
So I think the number of patients that you can reach with this technology, the flexibility of the platform that I've been referencing during the talk, really opens things up to treat a lot more patients than if you just had RFA, for example, and even RFA and EMR. I think you can have a good center there. I think you need to have a technology like liquid nitrogen spray cryotherapy to have a great center that's truly comprehensive when you're getting into the realm of tough strictures and cancer and all of these other these diseases and disease states that we've been talking about. So I'm hearing that unfortunately our half an hour is up. We're going to have to ask for more time next year. But feel free to submit questions, and I'll be glad to get back to you through the company and through the AFS with some more answers, and we can do that in a written form at a later time. But thanks so much, everybody, for coming.
Thank you, Dr. Smith. This concludes our session. Thank you, everyone, for attending.